Liver Part 2 Portal hypertension Definition. Portal hypertension is present when the portal vein pressure exceeds 20 mm mercury from 25 to 30 cm of water. Etiology mainly due to increased resistance to portal venous flow. Prehepatic causes, intrahepatic and posthepatic causes. Prehepatic causes congenital malformation of the portal vein. It's replaced by cavernomatous mass, neonatal umbilical sepsis, leading to thrombophlebitis of the umbilical vein and obliteration of the portal vein, portal vein thrombosis, secondary to intra-abdominal sepsis, using OCPs, liver cirrhosis, which is a rare cause, hepatocellular or pancreatic carcinoma, and finally, chronic pancreatitis. Intrahepatic causes, sinusoidal and post-sinusoidal liver cirrhosis, pre-sinusoidal bilharzial periportal fibrosis, post-hepatic obstruction, Budd-Chiari syndrome and veno-occlusive disease, Budd-Chiari syndrome, occlusion of the hepatic vein by malignant invasion and thrombosis which may be spontaneous or secondary due to polycythemia or using of OCPs, veno-occlusive disease, obstruction of the hepatic venules. The normal portal pressure equals 7 mm mercury from 8 to 12 cm of water. The average blood flow to the liver is about 1,500 ml per minute, of which 2/3 from the portal vein and 1/3 from the hepatic artery. In most of patients with prehepatic portal hypertension, the liver would be normal. Portal hypertension in cirrhotic patients due to diminution of total vascular bed by obliteration, distortion, and compression of sinusoids, compression of tiny radicals of portal and hepatic veins by excessive fibrosis, and development of multiple AV shunts between the branches of hepatic artery and portal vein. Sequelae and clinical picture: portosystemic collaterals, splenomegaly, congestion of the whole gut, and ascites. Portosystemic collaterals: these are multiple sites of portosystemic anastomosis, but they are collapsed under normal conditions due to low pressure of the portal circulation. With progressive portal hypertension, collaterals become engorged to divert blood away from the portal circulation. The important sites of those collaterals are lower part of the esophagus and fundus of the stomach, esophageal and gastric varices, in the anterior abdominal wall, caput medusae, lower rectum and anal canal, anorectal varices, and finally retroperitoneum. For the lower part of the esophagus and the fundus of the stomach, the anastomosis between portal circulation in the form of tributaries of left gastric and short gastric veins, and systemic circulation in the form of esophageal veins which drain into the azygos and hemiazygos veins. The anastomosis in the anterior abdominal wall between the portal circulation in the form of paraumbilical vein and systemic circulation in the form of superior and inferior epigastric veins. For the lower rectum and anal canal, the anastomosis between portal circulation in the form of superior hemorrhoidal vein and systemic circulation in the form of middle and inferior hemorrhoidal veins. In the retroperitoneum, the portal circulation is superior and inferior mesenteric veins, while the systemic circulation is posterior abdominal wall and subdiaphragmatic veins. Splenomegaly due to reticuloendothelial hyperplasia, and bilharziasis due to absorption of bilharzial toxins or congestion of the spleen secondary to portal hypertension may reach the right iliac fossa. It predisposes to recurrent attacks of splenic infarction, leading to severe stitching pain healed by fibrous tissue. Formation of adhesions between the spleen and diaphragm with the abdominal wall occurs. Secondary hypersplenism also occurs. Portal hypertension itself can lead to hypersplenism. In bilharziasis, splenomegaly is due to, first, reticuloendothelial hyperplasia, and then congestion. Ascites may cause an umbilical hernia. Infection of ascitic fluid may lead to primary or spontaneous bacterial peritonitis. Congestion of the whole GIT, it leads to anorexia, dyspepsia, indigestion, malabsorption, leading to abdominal discomfort which is wrongly attributed to splenomegaly. Venous hum can be auscultated on caput medusae due to increased blood flow. If hemorrhoids occur in a patient with portal hypertension, they are usually primary. Ascites causes multifactorial. Portal hypertension alone, it cannot cause ascites, but it only localizes the filtration of the fluid into the peritoneal cavity. Hypoalbuminemia, when albumin level drops below 3 grams per 100 milliliters, ascites usually develops. Salt and water retention due to high levels of aldosterone, estrogens, and antidiuretic hormone. And finally, increased lymphatic exudation from the surface of the liver due to lymphatic obstruction. Esophageal and gastric varices, they are present in the subepithelial and submucous with the periesophageal layers. Their enlargement leads to erosion of overlying mucosa, bleeding in the form of hematemesis, melena, or bleeding per rectum if massive. Bleeding is precipitated by high portal pressure, trauma, food reflux or gastric juice leading to esophagitis, bleeding. Esophageal varices is the commonest cause of hematemesis in Egypt, especially in bilharzisis or cirrhosis. Patient with esophageal varices may bleed from another region, such as gastric erosions or peptic ulcer. Investigations. The aims are assessment of functional capacity of the liver, detection of esophageal varices, detection of splenic sequestration and hypersplenism, and finally diagnosis of the etiology of the liver disease. Assessment of the functional capacity of the liver, done by liver function tests which will reveal prothrombin time and concentration. This is the most sensitive, they are disturbed. Hypoalbuminemia, liver is only the site of albumin synthesis. ALT and AST, they are moderately raised. Detection of esophageal varices by either fiberoptic upper endoscopy, barium swallow to visualize varices. In 90% of cases, they appear as multiple smooth, ground-filling defects. Doppler scan showing dilated portal vein and collaterals. Detection of splenic sequestration and hypersplenism. Blood picture revealing anemia, leukopenia, thrombocytopenia, or pancytopenia. Bone marrow examination revealing hypercellularity. Radioactive isotope studies using the patient's own RBCs tagged with chromium-51, diminished half-life of RBCs and increased radioactivity of the spleen. The spleen per river radioactivity index is increased. Diagnosis of the etiology of liver disease, immunological tests for hepatitis markers, and liver biopsy after assessment of prothrombin time and concentration. We have something called CTP classification or Child-Turgid or PACH. It's used to assess parenchymatous functions of the liver, divided into 1, 2, 3 points, and for each category: encephalopathy, ascites, bilirubin, albumin, PT, second prolonged, and INR. Encephalopathy, point 1 means none, point 1 for ascites means none, and bilirubin, point 1 equals to less than 2 mg per deciliter, for albumin, 1 equals to more than 3.5 gram per deciliter, and prothrombin time less than 4 seconds, and INR less than 1.7. While 2 points equal for grade 1 and 2 for encephalopathy or persistent induced ascites. Point 2 is for mild and moderate ascites, diuretic responsive, and for bilirubin 2 to 3 mg per deciliter, for albumin 2.8 to 3.5 gram per deciliter, for prothrombin time 4 to 6 seconds, and for INR 1.7 to 2.3. 3 points for encephalopathy, grade 3 and 4 or chronic, for ascites severe diuretic refractory, for bilirubin more than 3, for albumin less than 2.8, for prothrombin time more than 6 seconds, and for INR more than 2.3. CTP classification is obtained by adding the score for each parameter: A equal 5 to 6 points, B 7 to 9 points, and C 10 to 15 points. Patients with CTP class A can have major surgery. Class C cannot have major surgery. Treatment: silent varices. Primary prevention is important. Lifetime risk of first-time variceal bleed in a cirrhotic patient is 30% with mortality rate up to 50%. Endoscopic screening for varices should be done in all cirrhotics. Primary prevention with non-selective beta blockers such as propranolol or nadolol decreases the risk of first variceal bleeding by 40%. If large varices are present, especially if they have stigmata of bleeding, red streaks on the variceal surface, banding is indicated. Management of patients with actively bleeding varices, admission, even minor hematemesis may be followed by massive bleeding. Resuscitation: wide-bore cannula is inserted, blood samples taken, restoration of the patient's blood volume should be rapid. Correct coagulopathy: vitamin K is given IV, fresh frozen plasma may be needed. Prevent encephalopathy: blood in the intestine will be fermented to ammonia and other nitrogenous products, absorbed but they bypass the liver through portosystemic collaterals, leading to high level of nitrogenous products in the circulation, leading to hepatic encephalopathy. Even those which reach the liver are not completely detoxified due to disturbed liver function, should evacuate blood from GIT to prevent its fermentation by repeated enemas or colonic lavage. Oral lactulose, neomycin 0.5 gram every 4 hours to reduce the bacterial flora. Stop bleeding. Measures to stop bleeding are arranged according to the order of priority. If one method fails, the next is used. Number 1. Urgent upper GI endoscopy. To confirm the source of bleeding, it's diagnostic, and for endoscopic sclerotherapy or band ligation, it's therapeutic. Once the patient is resuscitated, he is taken to endoscopy department and esophagogastric endoscopy is performed under diazepam. If the varices are not bleeding at examination, look for other sources as peptic ulcer. If the varices are bleeding, they are injected. There are two methods for injecting varices, intravaricial and perivaricial method. Intravaricial, 5 ml of ethanolamine oleate injected into each varix just above the esophagogastric junction, leading to thrombosis. For gastric varices, intravaricial injection of histoacryl solidifies after contact with blood. Perivaricial method, small quantities of ethoxysclerol, 0.5 ml injected multiply alongside each varix, leading to perivascular fibrosis. Both methods may be combined. Injection can be repeated at 2 weekly sessions until the varices are obliterated. Band ligation now is the first choice. Encircle each varices by a tight band. Thrombosis of the veins is effective as sclerotherapy. Number of sessions less than sclerotherapy. Drugs, vasopressin, producing vasoconstriction of the arterioles of the splanchnic circulation, reducing the portal pressure. Dosage 0.2 unit per kilogram weight in 200 ml of 5% dextrose over 20 minutes. Disadvantages are diarrhea, colic abdominal pain, angina pains, so they are contraindicated in elderly, producing temporary controlling of bleeding. To prolong its action, it's combined with glycine or glypressin. Somatostatin can lower the intravaricial pressure. Balloon tamponade, used as temporary measure if bleeding is too profuse to permit endoscopic treatment, then arrange for repeat endoscopy or emergency, TEPS or surgery. Types: things taken, Blackmore tube or Lenton tube. The gastric balloon is inflated first by 200 ml of air and pulled upwards to press the gastric fundus. If bleeding continues, the esophageal balloon is inflated with pressure not exceeding 40 mm mercury, effective in controlling bleeding in 80 to 90% of cases. Transjugular intrahepatic portosystemic shunt or TIPS, TIPSS, recommended procedures in all previous measures failure. Under fluoroscopic guidance, a guide wire is passed through the internal jugular vein to the hepatic vein through the liver until portal vein branch. A stent is passed along the guide wire until it lodges inside the liver, creating a shunt between a portal and a hepatic vein. Very effective in controlling variceal hemorrhage. Complications: perforation of the liver capsule, fatal hemorrhage, portosystemic encephalopathy in 40% of patients, and shunt occlusion in 50% of cases after 1 year. The results of shunt operations and esophageal stapling in patients with bleeding varices are not satisfactory and they have high mortality. So, suspected bleeding esophageal varices, resuscitation, correction, coagulopathy, and antibiotic prophylaxis, then endoscopic banding or sclerotherapy. If successful, endoscopic surveillance plus beta blockers. If resistant bleeding, TEPS. Disadvantages of balloon tamponade include discomfort to the patient. The patient cannot swallow his saliva, aspiration of saliva. There are tubes which contain a special channel for aspiration. Liability to cause esophageal ulceration or stricture. Once the tube is deflated, there is liability of rebleeding in 60 to 80% of patients. Treatment of patients with history of bleeding esophageal varices. Bleeding from esophageal varices represents the major threat to cirrhotic patients, usually massive. Once the patient starts bleeding, further attacks can occur at any time. Management: first choice is repeated sclerotherapy or band ligation until the varices are obliterated. If sclerotherapy or esophageal banding failed, elective surgery is indicated provided that they are fit. Operations for portal hypertension. Shunt operations. The idea is to lower the portal pressure by shunting the portal blood away from the liver. So long as the portal pressure remains in normal range, the varices will collapse and bleeding stops. Examples: portocaval operation, the portal vein anastomosed to the inferior vena cava. Splenorenal operation, splenic vein anastomosed to the left renal vein. Disadvantages: deprives the liver of the portal blood flow, so it accelerates liver failure. Shunting the portal blood completely away from the liver leads to recurrent hepatic encephalopathy in 30 to 50% of patients. Bleeding from varices is related to size of the varices, bad liver functions, child C, widget hepatic venous pressure more than 10 mm mercury, WHV. And there is another note: oral lactulose is a disaccharide sugar which is fermented by the intestinal flora to lactic acid, combines with ammonia, and it has mild laxative effect which helps clearing blood from the bowel. Injection of bleeding varices is more difficult than in elective cases, as the esophagus may be full of blood, but the result is very gratifying as bleeding stops in 90% of cases. Side effects of injection sclerotherapy include retrosternal discomfort for few days, fever. Repeated injections can cause esophageal ulcer leading to bleeding. Repeated sclerotherapy, fibrosis and stricture. Penetration of the esophagus, mediastinitis, which is rare. And then, patients with portal hypertension will belong to one of the three categories: portal hypertension with silent varices, actively bleeding esophageal varices, patients with history of bleeding esophageal varices, a blood sample is taken for complete blood picture, liver function tests, coagulation studies, cross-matching for at least 4 units of blood. Overexpansion of the circulation is avoided as it may lead to heart failure, ascites, or renewed bleeding. Morphine and pethidine are contraindicated in these patients. Liver tumors, benign and malignant. Benign, true neoplasms such as liver cell adenoma LCA, non-neoplastic lesions, hemangioma, and focal nodular hyperplasia. Malignant, primary and secondary. Primary hepatocytes, hepatocellular carcinoma HCC, bile ducts, cholangiocarcinoma, mixed cholangiohepatoma. Secondary metastasis from GIT, pancreas, or breast cancer. Liver cell adenoma. Definition: this lesion is a true benign neoplasm of hepatocytes. It occurs mostly in women. Etiology: contraceptive pills are incriminated in its initiation and progress. Cessation of pill take can result in tumor regression. Pathology: gross picture. It's multiple in third of the cases. Soft, well circumscribed, light yellow in color. Microscopic picture: formed of sheets of regular hepatocytes with thin-walled vessels, yet no portal triads. Complications: rare, malignant transformation and spontaneous rupture leading to internal hemorrhage. Clinical picture: large LCA or liver cell adenoma, cause right upper quadrant pain, commonly asymptomatic, discovered incidentally at ultrasound examination or at laparotomy. Investigations: imaging by ultrasound, CT scan, or MRI. Laboratory liver function tests and alpha-fetoprotein was normal. Treatment: the OCP's intake is discontinued and regularly check change of the size of the tumor. Liver resection is indicated if doubt exists as to the possibility of malignancy or if large, more than 5 cm in symptomatic tumors. Hemangioma. Pathology: they are of cavernous type, may attain large size. They are usually harmless, occasionally rupture leading to serious bleeding. Diagnosis: ultrasound, focal lesion, CT scan with contrast. Treatment: the natural history is towards involution and calcification. They are asymptomatic hemangiomas. Even diagnosed at laparotomy, they shouldn't be resected. Excision only for lesions which produce pain or bleeding. Hemangiomas are the commonest benign tumors of the liver. Suspicion of a hemangioma is a contraindication for biopsy. Focal nodular hyperplasia, or FNH. Definition: harmless lesion of the liver, whose main importance is the difficult differentiation from other focal lesions. Etiology of FNH: it's unknown, but it's believed that they are caused by congenital abnormalities of the liver blood vessels. Some liver cells to receive more blood and then they grow into tumor-like structure. Pathology: gross picture: nodular firm mass, slightly paler than the normal liver. Prominent surface vasculature. Cut section showing stellate scar with radiating fibrous septa which divides the lesion into lobules. Microscopic picture: it resembles cirrhosis with regenerating nodules. The central scar and fibrous septa are apparent. Diagnosis: dynamic MRI scan, triphasic CT scan which reveals pathognomonic stellate scar and differentiates it from hepatocellular carcinoma or metastasis. Treatment: most cases require no treatment. If malignancy is suspected, explore and excise. Primary liver cancer. Etiology: HCC or cholangiocarcinoma. Cholangiocarcinoma infestation with the liver fluke Colonorrheitis sinensis, which cause ascitic cholangitis. HCC hepatocellular carcinoma, infection with hepatitis B virus or hepatitis C. Liver cirrhosis of any cause. The risk depends on the type. The highest incidence is post-hepatic followed by alcoholic. Aflatoxin ingestion, formed by the fungus Aspergillus flavus, which grows on grains that are stored in moist warm conditions as in Africa. Epidemiology: type of the patient, commoner in men. HCC is the main primary liver malignancy, prevalent in the Far East and equatorial African nations. Cholangiocarcinoma arising from the intrahepatic bile ducts, less common than HCC. Highest incidence in the Far East. 90% of HCC are related to viral hepatitis B or C or to liver cirrhosis. 10% of patients with liver cirrhosis will develop hepatocellular carcinoma. Benign tumors are more common in females. Primary liver cancer is commoner in males. Pathology of the HCC: gross appearance: the tumor is yellow in color, arising in a cirrhotic liver. Different appearances: massive form, forming localized mass; nodular form, multiple nodules; diffuse form, diffuse infiltration throughout the liver; microscopically formed of malignant hepatocytes with little stroma, with high vascularity derived from the hepatic artery. The cells possess acidophilic cytoplasm, large nuclei with acidophilic nucleoli. In well-differentiated, cells are similar to normal liver cells. In anaplastic, they are less similar. Complications: spread by lymphatic and venous routes, portahepatis nodal enlargement, peritoneal nodules, and less commonly lung deposits. Spontaneous rupture, subcapsular hematoma or massive intraperitoneal hemorrhage. Cholangiocarcinoma, adenocarcinoma epithelium lining the intrahepatic bile ducts. By the time the tumor is discovered, it usually has spread. Hepatocholangiocarcinoma, mixed type which behaves like hepatocellular carcinoma. Hepatoblastoma, form of hepatocellular carcinoma occurring in children, and the name is because of the similarity to the fetal liver cells. Clinical picture depends on the race, development of the country, and tumor size. Small lesions may be accidentally discovered through abdominal ultrasound examination, which is done for another purpose. Deterioration of health for a known cirrhotic liver, common. Hepatocellular carcinoma in black Africans grows rapidly and degenerates, leading to pain, jaundice, fever, and tender mass, commonly mistaken for an amoebic liver abscess. Late cases: pain, jaundice, ascites, hepatomegaly, anorexia, loss of weight, massive intraperitoneal hemorrhage. Investigations: lab and imaging. Lab, serum alkaline phosphatase elevated. The rest of liver function tests may show cirrhosis if present. Serum alpha-fetoprotein, AFP, tumor marker which is present in the serum of the fetus. The normal adult level from 0 to 10 nanogram per milliliter. The serum level of this marker is highly elevated with hepatocellular carcinoma and with testicular teratoma. A level above 200 nanogram per milliliter is suggestive. More than 400 is present in large or rapidly growing tumors. Benign liver diseases elevate level of serum but lesser extent. Serum alpha-fetoprotein returns normal level after successful resection. The re-elevation in the follow-up means recurrence. Imaging: ultrasound, CT scan, or MRI to detect site and extent of the tumor spread in the liver. Triphasic CT scan by IV contrast, this is mandatory, showing anatomical relations of the tumor to the liver vasculature, early arterial enhancement, and early washout. Chest X-ray and CT scan to search for chest metastasis. Intraoperative ultrasound to detect small lesions which may be missed by other imaging modalities. It allows safer resection by identifying major vessels and bile ducts. Laparoscopy to visualize the extent of the tumor. Peritoneal nodules can be seen, and perform laparoscopic ultrasound. PET scan to detect any systemic metastasis. 90% of hepatocellular carcinoma occurs in patients which are carriers of hepatitis virus or who have cirrhosis. Prolonged infection with hepatitis B or hepatitis C results in integration of the viral DNA into the host genome, resulting in malignancy. Rapid deterioration of health of a patient with cirrhosis. Suspect malignancy. In areas where hepatocellular carcinoma is a common tumor, an early detection program is recommended. Where known cirrhotics, have an annual ultrasound examination and alpha-fetoprotein estimation. An elevation of the tumor marker level or appearance of a focal lesion warrants further investigations to detect the tumor at earliest phase. The fibrolamellar hepatocellular carcinoma is a variety of the massive type which affects non-cirrhotic young females having better prognosis. Contains numerous fibrous septa which can occur in a normal liver. Treatment: surgery is the only hope for cure in patients with hepatocellular carcinoma, either hepatectomy or liver transplantation in suitable patients. Presence of cirrhosis makes some problems for patients undergoing resection, as bleeding tendency, poor function of the remaining liver, and diminished capacity of liver cell regeneration. Prerequisites for hepatectomy: child class A patient, no evidence or extrahepatic spread, no vascular invasion or portal vein thrombosis. The tumor is confined to one lobe of the liver, and in this case, the operation is either right or left hemihepatectomy. Prerequisites for liver transplantation: child class C patient, no evidence of extrahepatic spread, single lesion less than 5 cm, or small nodules, 3 small nodules each less than 3 cm. Milan criteria to one lobe of the liver. Preoperative guided biopsy is not desirable due to possible risk of hemorrhage from the highly vascular tumor and seeding of tumor cells. For inoperable cases, the following palliative options are available: transarterial chemoimmobilization, TACE, benefits of inducing tumor ischemia, and selective chemotherapy. The chemotherapy agent is loaded on gel foam and injected by angiographic techniques into the hepatic artery, then leads to the blockage of the artery, tumor ischemia, and the drug is selectively delivered to its target. Regional ablation by ultrasound-guided intralesional alcohol, intralesional radiofrequency, and intralesional microwave or laser ablation. Systemic chemotherapy. Liver metastasis. Metastasis can reach liver through portal circulation. This is the commonest route. Carcinomas of the colon, rectum, pancreas, stomach metastasize primarily to the liver. Hepatic artery in carcinomas of the lung, breast, kidney, uterus, or ovaries. Lymphatics, or direct spread from tumors of the gallbladder, stomach, or colon. Pathology. Liver metastatic nodules are usually multiple, white, and umbilicated. Because of the central necrosis, they are usually adenocarcinomas. Over 90% of patients have tumor deposits in other organs. Clinical picture: in addition to manifestations of primary tumor, the patient suffers from jaundice, ascites, papillary right upper abdominal pain, weight loss, fatigue, and anorexia. Investigations: search for the primary tumor. Lab tests reveal anemia, serum, alkaline phosphatase, and bilirubin are usually elevated. Imaging by ultrasound, CT scan, or MRI. Diagnostic: showing number and sites of metastasis. Treatment is usually chemotherapy. Palliative: presence of liver metastasis, advanced inoperable tumor. Chemotherapy in presence of other organ involvement. Systemic chemotherapy: if the liver is the only organ with metastasis, selective intraarterial chemotherapy through catheter, which is surgically inserted in the hepatic artery, reduces the systemic side effects of the anti-cancer agents and allowing the delivery of higher doses to the liver. Intralesional alcohol injection or radiofrequency ablation. Liver resection: the prerequisites are completely resectable colorectal cancer with no residual tumor. No extrahepatic metastases are found after a thorough search. Liver metastases: those are resectable with safety margin, such as solitary metastatic nodule removed in a wedge resection, multiple metastases confined to one surgical loop removed by a right or left hemihepatectomy. Differential diagnosis: hepatocellular carcinoma, metastasis, benign lesions as hemangioma, adenoma, focal nodular hyperplasia, cyst, parasitic or non-parasitic. The most common primary malignant liver tumor is hepatocellular carcinoma. Benign liver tumor is hemangioma. Few selected cases of metastatic colorectal cancer, if localized to one segment, can be treated by liver resection aiming at cure. Liver resection is done in the same session of the colorectal operation or later if the liver deposits appear in the course of the patient's follow-up. About 25% of these highly selected patients are cured. And this concludes our part for the liver and the whole liver.